In this section, we're going to talk about the diseases that affect primary hemostasis that lead to excessive bleeding. As we mentioned in the previous video, problems in primary hemostasis arise from defects in either the platelets, the vascular endothelium, or von Willebrand factor. We'll talk about defects in von Willebrand factor in a later video. First, let's focus on problems that affect the vascular endothelium. Problems with the blood vessels that lead to excessive bleeding are typically due to one or more of the following pathophysiologic causes: an increased fragility of the blood vessel, some sort of defect in the wall of the blood vessel, or consumption of the platelets and clotting factors due to damage to the endothelial surface. The four main diseases to be aware of in this category are vasculitis, amyloidosis, scurvy, and hereditary hemorrhagic telangiectasias. First, let's talk about vasculitis, whose name literally means inflammation of the blood vessels. Now, this isn't one disease, but it's actually a classification of diseases who all have the same underlying pathophysiology.
Morphologically, this vasculitis is shown in the form of cellular infiltration. You don't see the whole acute inflammatory reaction, you just simply see a cellular infiltration around the blood vessel, which may be accompanied by cell death and necrosis. And if you remember, fibrinoid necrosis is one form of morphological finding that you see with vasculitis. So the key word here is the vasculitis accompanied by cellular infiltration or fibrinoid necrosis. Where do we see these? We see these either in solid organs or in skin. And in skin, it's manifested by bleeding symptoms, signs like the petechia and the purpura. So a biopsy of that lesion will actually show vasculitis. This one here shows the cellular infiltration, and you see the blood vessels, and we know it's a blood vessel because there is these red blood cells enucleated in the middle of the lumen, surrounded by small cells around the blood vessels, predominantly tend to be of lymphocytic infiltrations or acute polymorph neutrophils. So this slide is from Rocky Mountain spotted fever, and the organism involved is rickettsia, and here the predominant cellular infiltrate you see lymphocytes. You can have the same process happening in organs or in underneath skin. The next slide is the fibrinoid necrosis. And remember what we said about fibrinoid necrosis is that there is inflammation of the wall of the blood vessel, and which will affect the integrity of the endothelium. Fibrin will leak out and be deposited around the blood vessel and giving this homogeneous pink color to the tissues, which are affected by the lack of blood supply. So you will have a necrosis which is fibrinoid in appearance. Simple English, it is pink homogeneous color.
So we know about Rocky Mountain spotted fever as one of the possible causes of vasculitis. We should also be familiar with meningococcemia, or infection with Neisseria meningitidis, which can cause vasculitis. Certain drug reactions can lead to vasculitis, and the aforementioned Hennig-Schönlein purpura, which you'll learn about in later semesters.
Another pathology which affects the blood vessels is the amyloidosis. And we've learned earlier in the fall that amyloid refers to a precursor of protein that is deposited outside the cells inside organs, and it can affect the function of these organs. So in this case, the amyloid is deposited extracellularly around blood vessels. So what happens is that when they deposit around the blood vessel, they tend to initiate an immunological reaction, and that is by activating the complement and bringing antibodies on board, and that will activate the cascade of the complement as well as bring on board the inflammatory cells, and as a result an inflammatory reaction will occur and damage the wall of the blood vessels, the endothelial cells. So this will contribute to the bleeding that can occurs with the blood vessels, especially if they are underneath the skin. But generally, when it comes to amyloid, it tends to be inside organs. So the bleeding will affect solid organs. So the image shown here shows the amyloid deposition. Now you will notice that it's also homogeneous and pink. And you will ask why it may not be fibrinoid necrosis. Well, when you look carefully with higher magnification, you will see that there is a fibrillar pattern. And nevertheless, it's still very difficult to differentiate the pink coloration or the eosinophilic coloration of fibrinoid necrosis and amyloid. And the only way to differentiate this microscopically is to apply a stain. And so there are specific stain or immunofluorescence antibodies as well that can actually mark the presence of amyloid versus, for example, collagen or fibrin and so forth. So the amyloid tend to deposit around the blood vessel and initiates an inflammatory reaction, as you see from the cellular infiltration of the blood vessels. Remember that this tends to occur in organs more than underneath the skin, and when it occurs in organ, it does affect the bleeding tendency or the disturbance of blood supply. It does affect the function of the organ, and we will see this later when we come in the renal system.
Now, scurvy is something that we don't see very often in the developed world. Scurvy is a deficiency in vitamin C. When you're deficient in vitamin C, that leads to defects in producing collagen. So when you've got a low amount of collagen, which is necessary for development of the vascular basement membrane, then you have a defect in the vascular wall. You've got defective vascular basement membrane. And that leads to increased permeability of the blood vessel wall, which leads to the characteristic findings that you might see with scurvy as typical with other disorders of primary hemostasis, and gingival hemorrhage, and petechiae. One particular finding that's fairly unique to scurvy is what are referred to as perifollicular petechiae. So these are the small petechial lesions that you see just adjacent to the hair follicles. Now let's talk about HHT, or hereditary hemorrhagic telangiectasia.
So far we've seen that involvement of blood vessel can be due to immunological damage, infectious damage, or nutritional. The following case is involvement of blood vessel due to a genetic condition, and that is the telangiectasia. So ectasia is a Latin word for dilatation. So you will encounter it again in bronchiectasis, for example, abnormal dilatation of the bronchus. So in this case, we simply have an abnormally dilated tortuous blood vessels, which tend to be very easily ruptured. And we find this in hereditary conditions known as HHT.
And these dilated tortuous blood vessels are very, very thin and highly fragile. And they can rupture, leading to petechiae, epistaxis, and other signs of mucocutaneous bleeding, which are the characteristic hallmarks of hereditary hemorrhagic telangiectasias. They may have very superficial telangiectasias of the skin, like this that you could note, or in the oropharynx, the conjunctiva of the eyes. These are common places to see these telangiectasias. Additionally, these patients are at significant risk for developing epistaxis or nosebleeds or other mucocutaneous bleeding. Be aware that there are other vascular causes of excessive bleeding, like Ehlers-Danlos syndrome, senile purpura, Cushing syndrome, and Hennig-Schonlein purpura. You'll learn about these in greater detail in other courses. Now let's talk about problems that might affect the platelets and lead to excessive bleeding. Platelet problems can be broadly separated into two big classes: qualitative defects, or decreased platelet function, and quantitative defects, a decrease in the number of platelets. And when the term for low platelets is referred to as thrombocytopenia, and this is usually considered less than 140,000 cells per microliter of blood. Be familiar with that term, thrombocytopenia, because you're going to be seeing it quite a bit throughout your career. A decrease in the number of platelets can be caused by typically one of three major mechanisms: increased platelet destruction or decreased platelet production, or sequestration of platelets in the spleen. Now, we're not going to talk about that during this module. You'll learn about that more later. First, let's talk about causes of increased destruction of platelets that lead to thrombocytopenia. One of the most common causes is idiopathic thrombocytopenic purpura, or ITP. Now, ITP is due to a autoimmune destruction of platelets by circulating autoantibodies. Now, when these platelets are bound to by the autoantibodies and travel through the bloodstream to the spleen, there they are consumed by splenic macrophages, thus leading to thrombocytopenia and the clinical manifestations of a disease of primary hemostasis, namely early bleeding and mucocutaneous bleeding.
This is a biopsy of the spleen, and you see the increase in size of the germinal center, because that's where the phagocytic cells are found. And there is also a number of blood vessels dilated and congested. This reflects the slow circulation, which actually helps in the removal of the abnormally large platelets from the blood flow. The slide shows a bone marrow smear showing the abnormally large megakaryocyte. As you know, the megakaryocytes are the largest cells in the bone marrow smear. The other three cells that you see, these are from the myelocytic series, myelocytes, and then there are 3 normoblasts and 1 plasma cell. So the center big cell megakaryocyte is the predominant feature. You will see it in the bone marrow with increase in number.
Now, ITP has two major kind of clinical manifestations to be aware of: the acute form and the chronic form. In the acute form, traditionally children are affected, and it affects both sexes equally. So if you see a child with ITP, it's most likely that they have the acute form. It typically has a rapid onset and is self-limited, meaning that it improves over time without specific cure. It's usually secondary to or follows an acute viral infection. So look for a child who's had a recent upper respiratory infection to develop bleeding symptoms 1 to 3 weeks after the infection. Conversely, in the chronic form of the disease, it tends to affect adult women under the age of 40 with a more insidious onset, so less rapid, less fulminant onset. It tends to have a more relapsing remitting course, where you have particularly worse times where the platelet count may be much lower, and then other times where it may be normal or close to normal. So it kind of comes and goes. In some instances, acute ITP can convert to chronic ITP, but that's very rare. The other difference is that in some cases, chronic ITP can be primary. If it is secondary, it's often secondary to a fairly severe illness. In certain instances, it may be due to HIV infection. It may be secondary to a collagen vascular disease like systemic lupus erythematosus, or it may be due to a oncologic process such as a B-cell lymphoma or chronic lymphocytic leukemia. Now, management of ITP involves or circulates around immunomodulation, or decreasing the body's immune system response so that we're no longer attacking our own platelets. The most common way this is done nowadays is through the use of intravenous immune globulin, or IVIG. IVIG is a pooled collection of antibodies, some of which will attack the autoplatelet antibodies themselves. Corticosteroids can also be used for this purpose. Another treatment that can be used is the application of anti-D antigen antibodies. The methodology here is that we're sending antibodies against the D antigen on red blood cells, which will occupy the splenic macrophages so that they ignore the platelets. What we're doing here is in effect creating a mild, hopefully mild, autoimmune hemolytic anemia in the process of preventing thrombocytopenia. Finally, splenectomy is sometimes used in the treatment of chronic ITP. Of course, this is removing the sites where the platelets are destroyed, allowing for a relatively normal platelet count and hemostatic function. Of course, there are other problems that might be secondary to removing a patient's spleen, but in some cases there is no other course of action but to remove the spleen. Now, ITP should not be confused with TTP, or thrombotic thrombocytopenic purpura. Though their names are similar, they're actually very distinct both clinically as well as pathologically. What I mean by that is that TTP is actually due to excessive clot formation in the bloodstream, which is using up all of the platelets. You can see this in the name. Thrombotic suggests that many clots are being formed. Thrombocytopenia suggests that that is leading to a low platelet count because they're all being consumed. And purpura is the clinical manifestation that we're aware of for primary hemostasis, mucocutaneous bleeding. How does this work with TTP? Well, TTP is actually due to a defect or deficiency of the ADAMTS13 metalloproteinase enzyme. What this enzyme is responsible for is breaking down von Willebrand factor multimers into small, normally functioning parts. When they don't get broken down, these ultra-large multimers bind to platelets, agglutinate, and activate them, leading to clot formation. Now, all of these small clots throughout the body lead to the clinical manifestations. TTP can either be inherited or acquired, and it typically presents with a characteristic pentad of symptoms. Those include fever, thrombocytopenia, as well as microangiopathic hemolytic anemia. This occurs due to the number of small clots that are forming in the small blood vessels, shredding up red blood cells as they're passing by. We also see transient neurologic defects, presumably due to small clots forming in the cerebral vasculature and renal failure. TTP can be confirmed after you think that this might be the cause based off the clinical symptoms by measuring the ADAMTS13 enzyme activity. And it can be treated with plasma exchange, where you are removing patient's plasma and providing plasma that does not have these extra large von Willebrand factor multimers. Now, something that actually shares a lot of similarity with TTP is hemolytic uremic syndrome, or HUS. Hemolytic uremic syndrome is also due to clot formation. However, unlike TTP, the underlying etiology is different. HUS actually follows infection, typically by E. coli strain 0157H7, which produces a Shiga-like toxin, so named because it resembles Shigella toxin. Now, Shiga-like toxin inactivates ADAMTS13, which leads to similar manifestations clinically as TTP. However, the Shiga toxin binds preferentially to receptors on the glomeruloendothelium in the kidney, and this localizes the reaction to the kidney and leads to some distinct clinical manifestations. Typically, management is supportive. The clinical manifestations of hemolytic uremic syndrome include fever and thrombocytopenia, as well as microangiopathic hemolytic anemia, so far very similar to TTP. The neurologic symptoms tend to be absent, and the renal failure tends to be prominent. Let's just contrast this with TTP for a moment. We see the big differences are the lack of neurologic symptoms in HUS and the prominent renal failure. Now let's look at the causes of decreased production of platelets that leads to thrombocytopenia. There are a number of mechanisms by which this occurs, and so here are a couple key diseases or disease states to be familiar with. Drug-induced thrombocytopenia. So thiazide diuretics or alcohol can cause a selective impairment of platelet production. Infections can lead to thrombocytopenia. Severe infections such as HIV or previously common infections like measles. A deficiency in B12 or folate, which have commonly been associated with decreased red blood cell production and anemia, but can also lead to decreased platelet production. Aplastic anemia is a failure of the bone marrow that leads to poor production of one or more of the cell lines of the blood, including platelets. Leukemia can lead to a leukemic infiltration of the bone marrow. Those leukemic cells will replace the normal hematopoietic cells of the bone marrow, which leads to a poor production of any of the number of multiple hematopoietic cell lines, including the production of platelets. Myelodysplastic syndrome will be discussed more in the section on hematologic malignancies, but this leads to ineffective hematopoiesis as well, which can cause abnormalities in all of the hematopoietic cell lines. There are two very rare diseases that lead to poor platelet functioning. These are Glanzmann's thrombasthenia and Bernard-Soulier syndrome. Glanzmann's thrombasthenia typically affects the GP2B3A transmembrane glycoprotein receptor. You'll recall this is responsible for binding circulating fibrinogen and leading to platelet agglutination in the final step of platelet plug formation. Bernard-Soulier syndrome tends to affect glycoprotein 1b, leading to defective glycoprotein 1b, which is responsible for binding von Willebrand factor and leading to platelet adhesion. Now, both of these diseases are rare, inherited in an autosomal recessive fashion, and manifest in laboratory studies with a normal platelet count, but abnormal bleeding time and or PFA 100, whatever test is used. So if you see a patient who presents with signs and symptoms of a hereditary disease that leads to mucocutaneous and early bleeding, but they have a normal platelet count, then you may consider getting a bleeding time or a PFA 100 to look for the possibility of them having Glanzmann's thrombasthenia or Bernard-Soulier syndrome.